Welcome to Get Moving TV. I'm Dr. Landon. I serve as your host. Today we have a guest who, unfortunately, I think will be operating on me at some point in my life. As we all age, our shoulders go, our knees go, our hips go. All my friends have, I don't know, tons of body parts. 50 years ago, or well, I'll say 50 years ago, when I first came in the community, I was in a dinner table with some elder folks, and that's really what they did. They took out their heart valve to pass around the table, took out their hip to pass around the table, and then all of a sudden here I am at that age. So we're rejoined by Dr. Fishman. 5 years ago we were talking about stem cell therapy, and there's been some just major advances. So I'd like to welcome Dr. Fishman.
It's great to see you again, Dr. Landon. Always a pleasure.
Well, just to remind people, so you're here in this area, so whereabouts do you practice?
I have several areas that I practice. I'm in Encino is one area also. We have a Lancaster office because I still take care of the military over at Edwards Air Force Base and their families. We really owe a debt of gratitude to the military, and anything that I think any of us in the medical field can do to help ease the burden not only of themselves but their family when they're overseas, because they still need medical care and help. So that's my honor to do that. So those are my two office spaces primarily.
Yeah, I was at the NIH in 2005, and that we were looking for the Iraqi war dividend. Did anything come out of that? Like radar came out, and it was prosthetic limbs, and so we ended up printing, 3D printing here, right, some limbs for kids. Well, nowadays, what does an orthopedic surgeon's practice look like? I mean, it used to be, you'd see, we were talking earlier, you'd see 80 patients a day, and it was all take care of the high school football team,
right,
and the like. So what does a modern orthopedic practice look like?
Well, because things have changed and technology has become more sophisticated, we still do some of the same things. Obviously, you come in with musculoskeletal injuries, and you'll still do the basics to start. You'll do physical therapy, you might give an anti-inflammatory, you might give a peptide in lieu of that nowadays. And then if the patient fails all of the routine types of treatment, in the old days it was, okay, surgery or live with your pain. It doesn't have to be that nowadays. There is a large section of interventional treatments that can be done in the interim, either preventing surgery or at least making it so the patient's much more comfortable where they're not as interested in having surgery. So some of those new derivative types of treatments involve orthobiologics. In the years that have come and passed over the last 5 to 10 years, we use some of the patient's own materials, their own biologic materials. We use PRP, platelet-rich plasma. Those are small little cells, as you well know, that float in your bloodstream, but they're very dilute. We go ahead and we take some blood, just a normal blood draw. Quite a bit though, 60, because the platelets are so dilute. And when we put it in a centrifuge, and we take that PRP. And then even now, over the last couple of years, we used to take the serum and we have to throw it away. Now the serum had something very valuable in it called alpha-2 macroglobulin, a very large tetramer. But we really couldn't do anything with it. It was sitting in 30 cc's of plasma, and you're not going to put 30 cc's in a knee. So they now came up with a new technology which has a filter, and you can now filter out all the fluid that you're not looking for, and you have pure alpha-2 macroglobulin, which sucks up the pro-inflammatory peptides and cytokines. Combine that with your PRP, which releases your growth factors, so they work together kind of in a consecutive fashion. And so we take those, and we now can use those inside the joint. Studies have shown a better result using that combination than just PRP itself. We can then rely on some of the old technologies. We've used viscosupplementation in the knee. It helps diminish the coefficient of friction. And we used to use that as a standalone. And it showed it was helpful in helping diminishing the forces, but didn't really make the joint heal any faster. It just stopped the breakdown. So somebody got smart and said, let's mix that along with the PRP and the A2M and see what kind of results we get. Well, lo and behold, we got much better results. So we're now using those. So that's one of the methodologies.
What happened to steroids? We just come in and everybody, you get your steroid injection, and boy, was there long-term effects where you had to move on?
big time. And there's a lot of good published articles showing very negative effects of the steroid, particularly on some of the ligamentous tissues and the tendinous tissues. It breaks down some of that type 4 collagen that makes up those nice tendon cords. And as it breaks it down, you can weaken the tendon. We've always known if you make the mistake of injecting a steroid directly into a tendon, that's probably going to rupture. Okay, and so we inject around it and those types of things, but it still weakens it. The more you inject with steroid, the weaker you're going to end up getting, and you're going to end up getting ending up with a worse joint, more inflammation, and more breakdown of the cartilaginous tissue, the tendinous, and the ligamentous tissue. So the only time in my practice nowadays I use steroids if somebody comes in with that big Pillsbury Doughboy knee and they're just so inflamed I really can't do anything. I just want to quiet it down before I really go ahead and go forward and do something with the biologics. So I'll do it once and only once, and then I'll leave it for that, knowing, and I tell the patient, there can be some long-term effects if we do it too often. I'm willing to do it once to get a knee in condition that I can help you with.
And then the 3-in-1 oil, this viscoelastic.
Yeah, the viscoelastic works very nice. Like I said, decreasing, and they used to use that as a standalone, and because it did something for the knee. But you would repeat it every 6 months because just like I joke with it, that 3-in-1 oil. I said it's like 10W40 for your car. You got to change your oil periodically. This thing runs out 6 months, 7 months, and you have to do it again. But when you utilize it with a biologic that has a propensity and an ability to be able to regenerate, or at least start your own body regenerating some of that tissue, then you get a much better response because they work synergistically with those various biological effects.
So before, I mean, you go and get your total knee and you'd be in the hospital for a couple days, and then 6 weeks of physical therapy, getting you up and out and about. And boy, I see my friends my age just next day they're running around like crazy people.
It really is, because we have new technologies and new medications. Part of the reason we used to keep them in the hospital so long is we used to put a hemovac in the knee, and we have to, you'd bleed and you used to have to absorb that out. Nowadays we have actually medications which we inject around the knee at the time of surgery. No bleeding. You sew them up and they can go home the next day or the same day. Okay? It's called tranexamic acid. Tranexamic acid, we can use the combination. We use a combination IV at the time of surgery before we start the case. We inject it, and then we go ahead and we use it in surgery. And it works very nicely. But again, we still try and make the total knee the last bastion. Because remember, they don't last forever. And if you do them in fairly young, healthy patients, and as our patient population gets older, and they're living longer, with living longer, and that's going to wear out. So they're going to get do-overs on that. And again, the secondary or the secondary revision total knees, they don't do as well as the primaries. And in fact, there was a great study by only he could get away with it, Dr. Hernigou. He was the father of stem cell, and he got patients together that needed bilateral total knees. And he convinced them to let him do one knee, a total knee. The other, he wanted to do the stem cells, intraosseous stem cells. And talk about follow-up. He's got a 15-year follow-up, which is almost unheard of. And so he followed them out for 15 years. In that group that he did these procedures on, the group that had both felt that they were just as happy with the stem cell as they were with the total knee. 20% eventually did convert to total knee. Very telling, though, the group that had the total knees, 40% had to have and ended up having a revision. So the bottom line take is try to treat your patients with these stem cell derivatives. You will find some of them will do just as good, will not have to have a revision, will not have to go on to have that total knee. In his study, 80%. And you will have a population with a much lower rate of complications, just as satisfied. And you can always reconvert to the total knee, so there's no downside with that. I think that was a very telling article, which is why I show that to my patients when it comes time when they come in, because many of them don't want the total knee. And I get patients from elsewhere, they've already been to 3 orthopedists. Everybody said, you need a total knee. And I say, there is a choice. And not everybody has a choice. If the knee's bad enough, I mean, you're stuck. But a lot of patients come to me when they're still have some joint space interval, the alignment is still good. These people are going to be like the Hernigue study. And I think and thus far, we've got great results with the interosseous combined with the intra-articular playing with the stem cells. And we do, of course, the periarticular, and we get good results.
I was just down at American Thoracic Society with one of your patients, and we put in probably 14,000 steps, and he's never gone on to a total knee. So very important. Yeah, well, and the hospital. I wrote a book called "Hospitals, Doctors and Hospitals: Rules for Survival," because hospitals are dangerous places.
Yes.
So how do you get around that? We used to be we're in the hospital and they get this Staph aureus, and multiple drug resistant, and so what's the modern approach? Are we still spending time in the hospital with these procedures?
You're exactly right. Those kinds of conditions still exist. So we try to limit going to the hospital to start with. And we do have some significant technology improvements where we have been able to do these total joints in an ambulatory surgery center where there is no other patients that might have bowel procedures, anything where there could be contamination. It stays very clean. It's just orthopedics or plastic surgery, and the infection rate is way down. And so doing that is preferable as long as you have a patient without any severe medical problems. Obviously, somebody with cardiomyopathy or some kind of pulmonary asthmatic condition where you think that they're going to have a problem post-op, yeah, you're still stuck in the hospital. And you warn them about that. But the hope is, with some of that new technology we talked about, I can get them out early. It's that multiple hospital stay, day after day after day, like the old days with the total knee. That exposure continues and continues. And if with the new technology, even if you get them in the hospital, if you can get them out in a day or so, it limits that exposure, though it's still there, as you've already pointed out.
Well, so as an orthopedic surgeon, take me through medical school. So what happens with the spine?
Well, there's been a big transition in what we do with spine. When I'm showing my age, but back in the 1970s, we were doing these Harrington rods, which were old school. And then as time developed, we started to be able to get the Quadrille de Boissé. These are the pedicle screws, and then the cages. And so these were areas that we were able to, with better technology, stabilize the spine. The problem still remains. We really don't have a great handle on the why people have the spine pain. They've done studies where they took a group that had no pain at all. These were people said, "No, I never had back pain," and they were in their 60s, 70s, and 80s, and 50s, and they did the MRIs, and they found degenerative disc diseases, they found protrusions, they found all kinds of pathology on the MRI with somebody who was asymptomatic. So the big be careful was doctors don't assume what you see on the MRI is giving your patient the pain. Finding out the reason for the patient's pain has been a problem. Back pain and back issues are prolific within the United States. It's one of the largest reasons for people's disability, billions of dollars for time off of work, and we're still looking for that. Why are they hurting like this? And putting screws, hardware, the results are not all so great. I mean, they're still on their narcotic analgesics afterward. They still have their disabilities. They're not going back to work. And so we don't really have the full answer yet, but we have better technology, less invasive, which can get better results than we've been able to with some of the new procedures like the disc seal procedure, which has been just recently approved by the FDA.
It takes a number of studies. I do FDA work, and it's about 10 years by the time you're done.
It took Dr. Pauza, who was the originator, 8 to 9 years to get that done. That's exactly right.
Can you break down the spine for me a little bit? Because it's not you just it's just one big thing back there, but there's different
really
anatomic pieces.
Yeah.
Yes.
So if we even just take a look at the lumbar spine, the spine is conceptually looked at as 3 different columns. You have the front or anterior column, which has the vertebra, the bone, and the disc. Then you have the back or posterior column. It has the facets, and lower down the SI joint. And then there's that middle column, which is where the space comes out and the nerves leave that epidural space to go down the leg. And so you can have pathology, and very often have pathology involving one or more of those regions. So you have to determine where your patient is primarily symptomatic, where that pain generator is coming from. And it's not always so easy. Even our exams, combined with our x-rays, combined with our MRIs, our EMGs, our NCVs, it doesn't always give you the complete answer. Even when I do spines and I'm looking at discal, I'm having to do annulograms. We no longer do discograms because it seemed to have damaged the disc, and there was bad correlation between the pain when the patient would hurt, and then you fix it and it wouldn't make any difference. So they came up with saying, well, you have these tears, and these tears leak, and that causes these cytokine leaks irritate the nerve roots. Well, you can turn around and put a little stem cell into those tears and then seal it with disc-seal. And the results have been surprisingly good. They did a study which was surprising. The person who did the study decided in order to prove it was really good, he did not want any backs that were never operated on. He only wanted backs everything failed. He says, you send me all of your failures. I want the people with disectomies, I want the people with fusions. Don't send me the people that are just fresh out of the gate. And he did the study. He had 65 to 70% good to excellent results. And this is part of the reason the FDA worked with him and gave him the patent. You know, patents in medicine are slim and none. Yeah. He got a patent. I was shocked. And so he gets, the good news for that is he gets to control, to some extent, who is certified to do this, because you cannot buy these special kits which have prothrombin and fibrinogen that make that fibrin mass that seals the disc, unless you get it through him. So he makes sure that you have to go to his course. You have to make sure he will test you in these cadaver courses, that you know how to get into a disc safely without injuring a nerve or anything else, and then you're certified to do that. Right now, unless I'm incorrect, I think there's only 5 of us that are certified in California.
Do you have to go to, it seems like everybody had to go to Florida for courses.
That's exactly where I had to go, to Florida for the cadaver courses, right. And we're in touch with Dr. Paws, and he occasionally will send us actually some patients, because, you know, he's in Florida and they'll get a call. He'll say, this just happened the other day. Patient lives in San Diego. They say, here's Fishman's number, go. He's done a bunch of them and gets good results. So we're kind of in that group to try to get patients better, because it doesn't, if you do those procedures, it doesn't preclude going further. Let's say it fails. You don't get the results you want. You still can't partake in the kind of activities you want. You're still open to go ahead and do those more invasive procedures if you want. It doesn't shut the door behind you, where it's more difficult once you've had, you know, pedicle screws placed and you have your PEEK cages placed. There's no that door shuts on the way out.
Well, there are some other advances, though. How about your own stem cells?
Yeah, there's different types of ways you can get stem cells, and there's really new. One of them is autogenous. You get them from yourself, okay? And there's 2 methodologies. One is we get it from your bone marrow. And most people get it, you know, from the back of the iliac crest, from their bone marrow. The other is you get it from some of the adipose tissue, which sits by the flank. And what you do is you can actually get those cells out, you can process them, and then you can take those cells and use them immediately to treat whatever you're going to treat, or alternatively, you can store it in a tissue bank, where the tissue bank will keep it for future times. So we get people who maybe could be in their 40s and they're doing something with their knee, and they say, but you know what? My other knee's not so great. I've had a little hip pain. Can we just store this elsewhere so I don't have to get these procedures each time? So we take enough so you can store, and then you take enough to do the procedure you're planning on doing that day, and you go ahead and do that. And that's still okay as long as they don't make an attempt to expand the cells. Because there are some banks that try to expand it. It sounds good because they say, we're going to give you 100 million cells. But as you do expansion, you know, you lose some of that stemminess because of those very special markers to start to disappear that give the cell its efficacy. So if you get the right bank and they treat it right and they take care of the cells correctly, people are doing that. You know, when the children are born, they're doing the same thing with the umbilical cord. Because when the future comes around 20, 30 years from now, who knows what kind of advances will be out? Who knows if you'll be able to take care of liver problems, kidney problems, even metastatic disease problems, neurological problems, the immunomodulatory problems with autoimmune diseases. I think we're just really on the cusp of determining what we can do with the stem cells. And you see big pharma starting to get involved in that as well too, because they see there's an advantage to it. The good news with that is I think lots of research will happen. The bad news, I think the expenses will go up significantly. But if the efficacy goes up and we can do a lot more and give people a better quality life while they're here, I think we've done our job to our community and for the people that we serve.
I just got presented with a drug for spinal muscular atrophy that's only $3.2 million. We have one for muscular dystrophy that's only $1.2 million at birth. These are little gene editing things. So in terms of the cost of these procedures, what is it, if you know, what does it cost for the storage in a year? So if I give you throw you in your liquid nitrogen, and 30 years from now, hopefully that company, because when they were cutting the heads off of whoever it was, throwing them in, and they'd thaw out.
There's usually a beginning cost. What the doctor harvests it, then send it to the lab. It depends, but it's anywhere from $2,500 to $3,000 for them to start it. They take it, they process it, and then there's a storage fee every year for the storage fee. It's not. I think it's like $500 a year to continue to store it, and they can make it less for you if you want it. If they'll pay 20 years up front. I did that with my granddaughter. When she was born, they sent everything, and they said, well, make a deal. You could pay it until they're 18 years old, and that was my gift to my granddaughter. I did that, we stored it, and I paid for 18 years. And I said, okay, at 19, I told my kids, you're going to have to take care of my grandkids at that point. So, and I think that's anticipating a future phenomenon in the use of it. Otherwise, there'd be no reason to do that. And it looks like it's coming to fruition. We see things getting better and more sophisticated as we start to determine better not only our genome, but our epigenetics and how to control our epigenetics. I think there's a brave new world as long as some of our social capabilities and our ethics don't fall behind our capabilities that we're determining as science goes forward.
So are we building superhumans? Is that to bring in the ethics? So you've opened that door up.
Yeah, that's possible. See, that's the thing that is possible. As you start to be able to do the splicing with some of the gene splicing nowadays, and you can, the fear is you can turn around and say, well, we need somebody who's very, very strong and muscular, not very bright, because we want them to be in the Army. And they won't be thinkers, but we'll just tell them, go do that and go take that hill, and they'll do it. We have another group where you just want them to be the intelligentsia. So what can we do to help their neural function? And I think that we take away from nature some of what's made us successful on this planet. The natural evolution as things go on, and nature does a better job than I think we do. So that's some of my fears, is that our scientific expertise and knowledge, to some extent, will and to some extent maybe is already exceeding some of our moral and some of our ethical capability, or at least what we've done to keep a cap on it and take a look. And I think something similar to that, although it's not part of this, is the AI involved with some of the medicine. We have to be a little careful with using AI in medicine. AI will give us false information, and you don't want to use false information in treating anybody and find out that that wasn't true. It was a, what do they don't call it a lie, they call it a hallucination.
Yes.
So we have to be careful in reviewing the articles that they say, and so it gets tougher in medicine when you keep up, where before we never had to worry about, are we believing the article, where before now it's not real, that study was never done. So these are all things, especially with stem cells, because there's a lot of research in there right now that's so prolific, and you want to keep up. But you have to be a little careful, because you're going to use that information, and if you use it incorrectly, I think it has some significantly dire consequences. So it takes people like yourself who have been interested in moving forward and going ahead and doing these studies and working with groups on a human-to-human basis to try and keep this. And I think that's why the medical community and the community at large owes you a debt, because it takes people like you to do that. I may be the guy that's getting the hands-on kind of thing, but if they don't have people to follow on the, I'm happy to run in your coattails and do it that way.
We're talking, but you need to treat patients as humans. You don't just
Exactly. Exactly.
and that's where I use large language model for a respiratory therapist to help the doctor to write the note because we don't have time. And so by my dictations, I put a recorder in the room, and there's somebody in Croatia who's listening to what the parent is saying, listening to what I'm saying, and we've got a standard set of what Dr. Landon thinks, and it gets input from both sides. So
That's great.
there is a human for that.
Yeah,
is my
and
understanding.
that's great that's going to happen as long as there's not an intermediary. That's what I was talking about with the AI, with an intermediary. It's you to your patient. And you've taken great pains. How many people can say, look, I'm looking at somebody way over here in Croatia, and they're over here in the United States. I don't get that opportunity, but you've developed the kind of system that can do that, systems that make that work. And I think as time goes on, doctors that are able to do what you do can be available to help people, not just here in our limited area, but all over the world. But they have to be able to make those allowances and some of those changes to be able to do that. That's what I meant. That's why I said I'm following your coattails, and you should show me how to do that.
Well, but there's been court cases where they've just let ChatGPT look up the cases, and that case never existed. That's
Exactly. They fined the
case.
attorney $5,000 because he didn't bother to check on it.
Yes. All right. Well, we're going to be talking more in just a little bit, but Ventura, Dr. Fishman is not that far away, but really what he's bringing is the willingness to take on these technologies, the experience and strength and hope that he's bringing after years of things that didn't work. That if you do get just a random MRI of your spine, there may be pathology, but it has nothing to do with how you're feeling. I think the other is just exercise and nutrition and not putting all the pain of our life into our back, not being pregnant with our big bellies. So if we can give up the Coke and all that, maybe we can put Dr. Fishman out of business. So though as we're getting older and older, so this is a deteriorating machine that we have. And we really appreciate Dr. Fishman maintaining us so that we can enjoy life and take care of ourselves. So Ventura, it's time for you to keep moving. Get what surgery you need.